Okay, so without further ado, let me invite our next speaker, which is Dr. Latha Selvaraja. Dr. Latha Selvaraja came all the way from Johor to be with us today, and she's going to be covering the important part of this lecture, which is management of acne vulgaris. Okay, so treatment, she will further dwell. It can be divided into several types. We have oral and also topical agents. So she will go through it. And hopefully at the end of the lecture, we are more clear what treatment we can give to our patients based on the severity. Without further ado, let me pass to Dr. Latha to continue with the next session.
All right. Thank you, Dr. Azura. And hi, everyone. I hope you're all still with us right now, okay? Because we're going into one of the most important topics about acne vulgaris, which is actually the treatment of acne vulgaris, okay? I hope before most of you all here have had the chance to look through our CPG. So what I'm going to do here is I'm going to highlight the important things in the management of acne, and I would want to actually show you what are the steps, what are the treatment at the different stages of acne that we should be recommending to our patients. The treatment of acne is based on the grade and severity. That is why Dr. Evelyn's lecture before this is actually very important, because you need to know what is the severity before you can decide, am I just going to leave this at topical? Do I have to be more aggressive giving a systemic treatment, oral antibiotics, or do I already have to refer to my dermatologist, okay? But whatever it is, the sooner we start the treatment for acne, it is better, because it is easier to treat acne rather than when the scars or the post-inflammatory hyperpigmentation come in. It's honestly very difficult to treat at that time. So when we talk about acne treatment, we can divide it into topical, systemic therapy, that is the oral. Usually we only have oral treatment. Then we come to the physical treatment, which is so much available out there. I need to enforce which are the ones that we are currently using. And of course, that's big group of cosmeceuticals, which I will try my best to actually explain about which is suitable and which is probably not. Okay. So what's new with this current acne CPG as compared to earlier one? In this CPG, we actually did a few of the updates on the newer topicals and systemic treatments for acne. We also talk about the latest evidence of the physical treatment. We added in this cosmeceutical because, there's so many things out there, okay, especially with this Korean K-pop and all that. Now, more and more of our teenagers, they are so into using so many things on their face, especially when they have acne, they try to self-treat. So we as physicians who are treating them, we need to know a little bit about this, okay? And then, of course, treatment of special population like the pregnant ladies and adolescents, what do we do for them? Okay, let's start off with topical treatment. We can never escape from treating acne without topical treatment. It is the mainstay when we treat mild or maybe the slightly moderate acne, and or topical is something that we'll use as maintenance, sometimes maybe even throughout, even after we have stopped our systemic therapy. The commonest agents that we use for our topical treatment is actually benzoyl peroxide, retinoids, and also topical antibiotics. Okay, other agents that's available: azelaic acid, salicylic acid. Okay, Dapsone sulfur, Dapsone we don't have. And this is new and upcoming, clascoterone. I'm going to talk about this because it's going to come to our shores very soon. It's already registered in Malaysia. We are just waiting for it to come to our shores. Okay, and when we prescribe topical treatment, you can prescribe cream one by one, or we can even give them as a fixed combination, or we can prescribe 2 creams at a time. So let's start off with topical treatment. How do we do topical treatment? We can use, the most common ones we usually use is actually benzoyl peroxide and also retinoids. Benzoyl peroxide, we can use it as monotherapy. That means only benzoyl peroxide alone, or we can combine it with other topical therapy. Usually we combine it with the retinoids in our mild and slightly moderate acne. About topical retinoids, we can use it, the one that when you want to choose let's just say you want to choose one topical, that's one you want to give your patient. If this is mainly the comedones, the open and closed comedones, you would prefer to use topical retinoids for our patients. But then if there's an inflammatory acne, like, the pustules or the papules, it's very inflamed, we would prefer to use a topical benzoyl peroxide as the first monotherapy. But of course, when we use two topicals, especially when the patients have, moderate, slightly moderate, not very bad acne, it's best to actually combine two topicals. Okay, here I want to highlight about topical antibiotics. We have the commonest one that's usually used is clindamycin. Please do not use it as monotherapy in acne vulgaris because this will cause a bacterial resistance. Whenever you want to prescribe topical antibiotics, you need to combine it either with the benzoyl peroxide or the topical retinoids. Okay, about topical azelaic acid, this is the cream that we would use, especially for those patients who have acne with this post-inflammatory hyperpigmentation. So that is the best time to use the azelaic acid. Okay, and when you think that the acne, just now we talked about the CAS classification. One is almost clear, two is mild, right? So the mild one, you see a bit, you can, and then after it's like, less than half the face is affected, but you can actually see it visible. Please do start off with a combination topical therapy because that works better than a monotherapy. So when you're giving topical benzoyl peroxide, please remember always to advise your patient when they're first time using benzoyl peroxide, because benzoyl peroxide can be actually quite irritating. So when they are going to use it, you must always warn them that when they first start using it, they'll feel a bit of irritation, sometimes erythema. If they cannot tolerate the irritation, you can either tell them to use a non-comedogenic moisturizer first, then use the benzoyl peroxide, or use the benzoyl peroxide every other day until they can tolerate it, then they can go daily. Use a lower concentration. We have lowest is 2.5%. Usually we start off with 5%. And why we always tell our patients use benzoyl peroxide in the morning, because benzoyl peroxide can actually bleach the clothes. So, if they go and use it at nighttime, sleep on a pillow, all their pillowcases, the beautiful or expensive one, it's all going to be spoiled. So, you have to warn them about this. If not, they'll come back complaining to you. Okay, how about when you prescribe topical retinoids? Topical retinoids, it actually causes a lot of photosensitivity. So you must tell them that it can be applied only at night, and the next day they must actually wash off. It can be applied on the area that's affected or the entire face. That is why we like topical retinoids, especially as maintenance therapy, because when they're actually finishing their systemic therapy and they want to stop it, right? So when we are using the maintenance of topical retinoids, it can actually prevent new acne from coming up. But also remember, topical retinoids also can cause a lot of irritation. So always warn our patients about that. If they have irritation, stop for a while, use moisturizer first, then restart. Maybe when you restart, they can also restart at every other day, or else they can use moisturizers, then only use the topical retinoids. Okay, maybe you want to ask me, there's so many topical retinoids out there. There is actually the tretinoin, there is also the adapalene, and then the newer ones are going to come up. Which one is better? So when we look through the literature, we found that there is no one topical retinoid which is superior than the other. But so far, we see that the topical adapalene has the least irritating side effects as compared to the other tretinoids. Okay, so what's new in the topical treatment? Number 1 and number 3 is already registered in Malaysia. So look out very, very soon that they're here already. I think some of you might have had samples also to use. Okay, so first, topical trefarotene. Okay, it's a fourth generation topical retinoid. Topical clascoterone, we are all actually very excited about it because this is the one and only topical treatment which addresses the sebum production. Okay, and then the other one is topical minocycline foam 4%. This is still not available in our country yet. So trefarotene is actually a gamma selective retinoid cream. It's actually a 4th generation retinoid cream. Okay, so it is available at that strength. It's about 0.005% strength cream. Okay, so the studies that we have looked through, it definitely shows there's improvement in the both the inflammatory and non-inflammatory acne lesions, okay, as compared to placebo. And it also, similar to other retinoids, it has the side effects of erythema, scaling, and stinging sensation. Okay, and trifarotene, as with other retinoids also, it has this comedolytic, anti-inflammatory, and also anti-pigmenting properties. So those who have acne with pigmentation, retinoids, including trifarotene, can be considered. So this is the one that we are all very excited about. This is first in its class topical treatment, topical clascoterone. Okay, it is actually an anti-androgen. How its mechanism of action is that it competes with this dihydrotestosterone. When it blocks that, that is how there will be reduction in the sebum production, and that is why this is the only topical medication that can address the problem of overproduction of sebum in a patient with this high hyperandrogenism. Okay, but remember, this is topical, so we only use it to mild and slightly moderate acne. Okay, and studies have shown that topical clascoterone can work very well for non-inflammatory lesions and also the inflammatory lesions, and is also very well tolerated. It's one of those that you want to use to control the sebum production as a topical agent. This is something we can use, and also as a maintenance, especially after a patient completes their isotretinoin treatment. So how about oral and systemic treatment? When do we start? When they're already CAS 3, moderate, there is more than 50% of the face is actually already involved with acne, you should immediately start systemic treatment. So systemic treatment for acne, they have oral, and we have oral antibiotics, we have oral isotretinoin, and there's also oral hormonal therapy, such as the oral contraceptive pills, spironolactone, and metformin. Let me go through one by one. Oral antibiotics, we use it for moderate acne. Okay, it has a very good antibacterial action against the Cutibacterium acnes. So the one that we usually use oral antibiotics, the most common one what we have is oral doxycycline. Okay, so these antibiotics, whenever we start using it, by week 6 to week 8, we should already evaluate the response. That means once the patient starts, okay, we must already tell them, okay, within 6 weeks, we need to see whether there's improvement or not. And if there is improvement, we should actually continue, but do not exceed oral antibiotics beyond 3 to 4 months, because this, again, if we prolong the use, it can cause bacterial resistance. Okay. Another thing to talk about oral antibiotics is that please do not combine oral antibiotics and topical antibiotics. That's not something that that is advised. Okay, if you're giving oral antibiotics, topical treatment that you can give is actually topical benzoyl peroxide or topical retinoids. Okay, and when you're giving oral doxycycline, all right, before I go to this, when you're giving oral doxycycline, please remember to advise the patient to take it, after food, all right, and then if don't take it on an empty stomach, because it can cause a lot of gastritis pain, and also warn them there's a bit of nausea with it. And the other thing with doxycycline is that you also have to warn them of the risk of allergy, and do not expose too much to the sun, because they can also be photosensitive while on oral doxycycline. All right. Okay. What is new in oral antibiotics? This is another tetracycline group. It is the oral sarecycline. We do not have it here yet, but it's interesting to know, because very soon I hope that it can come in, because the sarecycline is actually a narrow spectrum tetracycline group of antibiotics. So when I was mentioning earlier that doxycycline, we cannot use it for too long because the risk of bacterial resistance. With this sarecycline, because of its narrow spectrum, right? So it has very low activity against the gram-negative. So the risk of the bacterial resistance is actually very low. So this is something we are all looking forward to when it's coming to our shores, other than having doxycycline alone. So isotretinoin, that's the king of our topic, of our systemic treatment for acne, honestly. Okay, for those acne patients who are like moderate, we have already tried oral doxycycline, you started 6 weeks, not better, or completed oral doxycycline and then they get better, but then they relapse again, meaning the acne come back again, coming to the grade of moderate. So this is when you need to refer to us, dermatologists. This is where we will start using oral isotretinoin for our patients. And if your patients present to you straight away with severe or very severe acne, with nodules or cysts, please do not waste their time giving, oral antibiotics, please refer to us dermatologists, because we need to start them isotretinoin as soon as possible. Because once they develop this nodule and cyst, right, the risk of the scar is actually very real, and the scar can be very deep, deep scars that, you know, at the end, when you want to try to treat it, it's very, very difficult. That's why it's always easier to treat acne early so that we can prevent the complication of scars. So isotretinoin, when we're giving our patients, we always advise them to take it with food so that it will be absorbed very well. And isotretinoin, whenever we give, we try to avoid it in giving in females in the childbearing age, because it's highly teratogenic. Even one tablet taken and the patient gets pregnant, we have to send them for termination of pregnancy, because it is so teratogenic, and that is why we limit its use to dermatologists only. For the male patients, whenever we are giving to them, we advise them also, male and female, please also remember not to donate blood, because the risk of teratogenicity with isotretinoin. But it's a really, really effective drug for acne vulgaris. Okay, for those patients who are, for female patients who are suspected to have hyperandrogenism, so this is where we will consider oral contraceptive in these patients, okay? We have combined oral contraceptive, okay? We have the one with the anti-androgen property inside. So these are the, whether it is using the progesterone together with the oral contraceptive, or using the one with the anti-androgen inside, either way, studies have shown that they are equally effective in treating acne patients, female acne patients who has hyperandrogenism. Okay, the other treatment that we can use for them is also spironolactone. Okay, spironolactone, there's good evidence of low dose spironolactone in ladies who have features of hyperandrogenism. The use of metformin itself, it is beneficial, but the study has shown that it is used usually as an adjunct, not as effective as using OCPs or spironolactone on its own. Okay, let me summarize about oral treatment or systemic treatment. So, you know, oral doxycycline, tetracycline, or even erythromycin, if they're allergic to doxycycline, it can be used in moderate to severe acne vulgaris. The response was evaluated at 6 weeks, and the target duration should not exceed 3 to 4 months. Means once at 3 to 4 months, you need to stop the treatment. Do not combine systemic antibiotics together with topical antibiotics. If you're using systemic antibiotics, please use the other topicals like benzoyl peroxide or retinoids. And isotretinoin, if the patients present to you with nodular cystic acne already, or if you're treating your acne patients with doxycycline, they are not getting better, or they relapse and come and again they develop moderate to severe acne, please refer to us for the isotretinoin treatment. And remember, isotretinoin can only be prescribed by dermatologists, okay? All right, how about physical treatment? So in physical treatment, we have these intralesional corticosteroid injections, comedone extractions, chemical peels, and the ever famous lasers, okay? So for physical treatment, if you're giving intralesional corticosteroid, usually we reserve it for the nodules or cysts, which is actually not actively infected. So by injecting it inside, it can actually reduce the nodule or the cyst very fast. But you need to know how to use it, the dose of doing it, because if you do a too high dose of corticosteroids, okay, it will induce skin atrophy, okay, then there's a lot of dyspigmentary changes as well. Comedone extraction is another thing that you can do for all the, especially the open comedone, so also have to be very careful so that we do not damage the skin. Chemical peels also, when we are looking through the evidence, they can be used, but it's usually as an adjunct in the treatment of acne. Maybe you're using some systemic treatment, then we can add this on to actually improve the acne in the patients. And the preferred choice of chemical peels are usually salicylic acid and glycolic acid peels. Okay, laser treatment, how good is the evidence? So when you're talking about energy-based devices, right, there's light-based therapy, there's laser therapy, and radio frequency treatment. Among all is the laser therapy, especially the Nd:YAG and the non-ablative fractional laser. These are the ones that they show a little bit of evidence for the treatment of acne, and again is actually used as an adjunct. It is not one and only treatment for acne. You need to actually use it in combination with maybe another topical, or else with a systemic therapy. So far, it's very, very difficult to make a conclusion like how effective this is, because there's various studies on the lasers that's used, and sometimes they combine it. So it's very difficult to make a conclusion out of this. But what we can see is that laser, it is useful as an adjunct in treating acne vulgaris. And to support the light-based therapy and radiofrequency therapy at this point of time, there is insufficient evidence. Okay, let's go to cosmeceuticals. This is something that, we are looking through it. We looked through it during our CPG when we prepared the CPG. So let me tell you what are actually these cosmeceuticals. They are things that you do not need to prescribe. Patients can go out there and they can buy it. They contain non-medicinal ingredients inside. So cosmeceutical products, they cover cleansers, these cleansing devices, moisturizers, sunscreens, and also the patches that these teenagers like to use, the hydrocolloid acne patches. Okay, the active ingredients in it here, you can see, they're corneolytics. That means they have to reduce the acne itself. So they have retinols, AHAs, okay. They have sebum controllers, especially the nicotinamide. Certain cosmeceuticals have antibacterial agents that you can see here, the aloe vera, the propolis, the tea tree oil, and some of them have antioxidant ingredient in it, like the vitamin C. All right, so these are all falling into group of cosmeceuticals where patients can actually buy these. These are products that, they incorporate this into their, this very magic cream or something and sell it to the patient so that, especially for acne patients. Okay, how is the evidence for the use of cosmeceuticals? This again, when we look through the evidence, the studies that they have is very heterogeneous. It's like, one study uses this at this different concentration, another study using so many combinations. So it's very hard to say one cosmeceutical is actually, better than the other. This study is better than the other because it's so heterogeneous, because a lot of them have combination of ingredients. So what we can say is the existing studies that on these cosmeceuticals, they're actually very small in sample size, and the quality of the study is also very low. But what finally we can conclude is that if patients want to use it, they can use it as an adjunct to in the management of acne vulgaris, wherever the management is. That means, is it a mild acne, moderate acne, but definitely not for severe acne already, okay? Okay, so we came up with this beautiful algorithm on how to manage our acne vulgaris. So you can see here on your left-hand side, if the patient has mild, that means, less than 50% of the face is actually involved, have this active acne on, you can try topical treatment. If it's really, almost clear, maybe single topical treatment. But if there is, like almost about less than half, but you can actually see it visible, do go straight for combination topical treatment. Sometimes you may ask, if combination of topical treatment, is it better to use two separate products or a fixed combination? Actually, evidence showed that, either or, it doesn't matter. The efficacy is the same. But of course, in a fixed combination, it is actually more practical to use because, you use it only one time, so it's not messy and it's fast for the patients to use. So the topical treatment that we would recommend is actually going for topical retinoids, especially for the comedonal type of acne, or topical benzoyl peroxide, especially for the inflammatory type of acne. And if it's a moderate acne, combine at least two of these. Azelaic acid, use it when that you see a lot of hyperpigmentation in your patients. That's when the topical azelaic acid will come in very useful. But if the patient already has more than 50% CAS, CAS grade 3, you need to add on a systemic treatment at at the primary care level. You can use antibiotics such as doxycycline, tetracycline. Okay, but then if they don't work better, they get relapses. Okay, please refer to us, dermatologists, and we can initiate isotretinoin. When you start oral antibiotics, remember, assess them at 6 to 8 weeks, and if they're doing well, continue at 3 to 4 months. Please stop the oral antibiotics. If not, you're going to cause a lot of bacterial resistance. Okay, in pregnant lactating mothers, what can be used? We can use benzoyl peroxide, we can use topical antibiotics. So remember, I said earlier, do not use topical antibiotics as a monotherapy, always combine it, all right? Okay, we can use topical azelaic acid and topical salicylic acid. If the acne is very severe, we cannot use doxycycline in pregnant and lactating mothers. So we need to choose macrolides for them. Okay, all right. And then once they've delivered, no more breastfeeding, then we can, if the acne is not better, then they have more choices later. And for physical treatment, they want to undergo anything, it's chemical peel and also light-based therapy. Okay, how about adolescents? Adolescents here, we take it as patients of about 10 years and above. We can use topical benzoyl peroxide and topical retinoid safely. Oral tetracycline we can use, but for those aged 8 years and above. And for oral for oral isotretinoin, studies have shown that it can be safely used for 12 years old and above. Okay, here I'm coming to the end of my presentation. I hope I really got my message across. Okay, acne definitely is a very common problem. That is why today we are like this overwhelming response of like 1,000 people listening to us. All right. And remember, you play an important role in starting acne treatment early, because the earlier you start, it is very important to reduce all the complications like scarring and post-inflammatory hyperpigmentation. Use topical treatment. I see topical treatment at all stages of acne. Okay. It's alone in mild to moderate acne, and in severe acne, once the systemic treatment is done, then we will actually go for topical treatment as maintenance. And systemic treatment should be considered in moderate to severe acne. And in terms of the physical treatment, the steroid injections and all, and also cosmeceuticals, the evidence is for it to be used as an adjunct therapy to our current treatment. And consider early referral to us dermatologists if they already present to you with nodular or cystic acne, all right, or if your oral systemic antibiotics is actually not working very well or patient relapses, please refer to us so that we can start off with the next treatment option for the patients. With that, I thank you so much for listening.
Thank you very much, Dr. Lata, for very enthusiastic. You can see the enthusiasm in her in treating all her acne patients. Okay? So I hope she has given a clear explanation how we can treat patients, ranging from topical treatment, systemic treatment, and she also covered the physical treatment, which are lasers, okay, and all the other modalities that we can use to treat acne patients. Okay. So I hope everybody is clear, as in depending on the severity of the acne, what treatment can be given for the patient.